Hello, good evening. Welcome back to my IVF Answers and the European Fertility Society. We are back today with another topic. If you had a chance to join us yesterday, we also had a webinar. We talked about fertility experience during your IVF treatment, and today with a psychologist. And today we will go to another topic, which is IVF failure, causes, strategies, some new insights, and of course we have our guest with us today. As you can see, Dr. Marbán is right here. Dr. Esther Marbán is with us. She's the Gynaecologist Fertility Specialist at Clínica Tambre, and she's joining us today from Madrid. So I'm really happy to have you here. This is not our first webinar with you, so I'm really excited to have you back. We've done it for quite some time, so it's lovely to have you here. I do remember we had previous webinars even during pandemic, etc. So it's been a long way, but I'm really happy to see you here today. And of course, this topic is definitely important one and not an easy one as well. So Dr. Marbán will walk you through all the steps that you can do to overcome IVF failure, all the causes, all the strategies. So she will start with the presentation on our topic first, but there will be time for your questions. As always, please just put those in the chat section so that Dr. Marbán can answer. We have 1 hour for this, so please remember to put the question during your presentation or afterwards, and I'm sure Dr. Marbán will be happy to help as much as possible. Remember, it's all anonymous and it is being recorded. So if you have anything that's on your mind, I can only encourage you to type this in so we can get as many answers for you and simply answer as many questions as possible. And Dr. Marbán, ready to start?
More than ready, I would say.
Perfect, right? Glad to hear it. And I think we can go ahead with the presentation first, and as I mentioned, Q&A will start right after our presentation. Let's go ahead.
Thank you, Caroline. So first of all, I would like to say that it's a pleasure for me to have the opportunity of joining you today with that interesting topic that I guess that would be also quite interesting for all the audience. And as Caroline said, please, you have questions, you don't hesitate in just writing them in the chat, and we'll go through them later on. So today we are talking about understanding and overcoming IVF failure, causes, strategies, and new insights. So we will go through the most common causes of IVF failure, and we'll also talk about the treatment options. We'll also talk about artificial intelligence in fertility and take-home ideas. So let's start with the most common causes of IVF failures. So the first and the most important one are the factors related to the embryo. So the embryonic abnormalities may be caused by a low ovarian response or low ovarian reserve with no embryos obtained. Of course, will be one of the main factors. Also related to the poor egg quality. The main factor, the male factor that we'll talk about that later on, and the most important one is the poor embryo morphology and poor embryo quality. So in the end, it's true that the way the embryos are classified will also give us information about what we may expect from that embryo transfer. So good quality embryos might potentially have an increased implantation rate, and of course let's say like the low quality embryos will have a different and lower potential implantation rate. And apart from the quality, it's also really important to talk about the potential chromosomal abnormalities. So that factor is the most important one to have a failure of implantation. So in the end, if the embryo we are transferring it's not a healthy embryo, of course, if we haven't done any tests to check if the embryo was healthy or not, the chance of implantation with that embryo will be potentially lower. Apart from that, as I said, the most important factor is the embryo, but then we also need to talk about other factors that are non-factors to have a lower or a failure of implantation. So the second factor is the uterus and the endometrium. So some problems related to the uterine structures such as fibroids, polyps, adhesion, some kind of malformation in the uterus can also end in a failure of implantation. And also some potential alterations in the endometrium can also let the patient have that failure of implantation. So apart from the window of implantation, which is the moment when the endometrium is like more receptive for that implantation, sometimes like chronic endometritis can also end in that kind of problem. So we will go through those problems in the following slides. And finally, apart from the uterine factors and also the embryo ones, we should also talk a little bit about the clotting and immunological disorders that are also known to be a reason to have a failure of implantation. So, as we were saying before, the embryo is the most important part that has to be, let's say, checked, examined, to talk about that failure of implantation. It could be like around 70% of the implantation failures. It could be caused because if we are talking about good quality embryo that maybe have not been tested, in the end, the chance of having an ongoing pregnancy with no tested embryos, of course, if they are not healthy embryos, would be quite reduced. Apart from that, as we said before, the uterine abnormalities and also immunological factors are also endometrial factors. So we will go through those techniques and like tests that can be done to try to exclude those factors and also to find a proper treatment for the patients that like come to the consultation or that we suspect that they could have that failure of implantation. So first, we were saying before that one of the factors could be just a male factor. So we need to examine the sperm in the best and most accurate way possible. So first, apart from doing a normal and basic sperm test, we always prescribe a test called a COMET test, which is designed to check the single and double-stranded DNA fragmentation. So sometimes we find alterations and problems related to the DNA fragmentation in the sperm that can be treated first and can be also, well, in the end, we are able to select the sperms in a different way than normal to try to lower the risk of selecting fragmented sperms to fertilize the eggs. So when we find like certain alterations in the DNA fragmentation, depending on what alteration we find, we use different techniques to select the sperms by the time we fertilize the eggs. So apart from having, let's say, a normal and general test in the sperm, it's also important to to have a different and, let's say, more extended test about the sperm to know more about that part and also to find the best way to select the sperms if needed. So one of the main factors that are linked to that potential failure of implantation is the egg quality. We were saying before that we need to classify the embryos, and of course the good quality embryos will have a higher chance of implantation than the, let's say, poor quality embryos. So it's true that some patients, even though they are young patients, they might have problems in the egg quality. So it's difficult that we can try to have different strategies to improve the egg quality. So the first one will be using some kind of supplements such as melatonin. We can also use inositol, sometimes also coenzyme Q10. So those supplements are supposed to increase or to improve the quality of the eggs. Apart from that, when a patient comes to our clinic with previous treatments in other clinics, it's possible to change the stimulation a little bit to try to have at least a better response if possible, and if possible also better quality of the eggs. Sometimes when we have a low ovarian reserve and if we want to maximize the options of having a higher number of embryos to be tested in the event that we want to do the PGT, the pre-implantation genetic screening in the embryos, we can use different strategies as the dual stim, in which we do back-to-back two stimulations. The first one would be done in the normal way with the proliferative phase, starting with the menstruation, and the second stimulation will be started some days after having done the egg retrieval in what is called the luteal phase. So in the end, we are doing like 2 stimulations in 2 different moments of the cycle, with the idea of also knowing how the ovary works in different moments of the cycle, and giving the chance of having, as I said, better outcomes. When we are talking about, of course, a different treatment, which is the egg donor treatment, and of course we will give also some information about that in the next slides. It's true that donors are, at least here in our clinic, are also really young donors. Normally they are also like in many cases they are already fertile donors, so in the end it can also give us like better chances of implantation in the patient. So apart from that, we were saying in the previous slides that it's important to have a good quality embryo and also transferring a healthy embryo. So in the past, we did transfers on day 2, on day 3, but it's true that it was like the past. Now we know that it's like the chance of getting pregnant with a blastocyst embryo are much higher. Apart from that, it's the best moment to do the biopsy of the embryos if we want to have them tested for that chromosomal abnormalities. So in the end, it's that in the past, we didn't have the chance of using that extended culture, and we didn't have the chance of doing transfer on blastocyst stage because of the technology we had by that time. But currently, we do transfers on blastocyst stage in 100% of patients. So all patients that come here to our clinic also like have the chance of doing the embryo transfer on day 5, which also has proven to increase the implantation rate. We were saying before that the embryo is the most important part of that implantation procedure. So we try to use like some techniques to try to improve the results as much as we can. So one of them is called the Gary time-lapse incubator. So that incubator is designed to take pictures every 5 minutes from the embryo. So it means that we don't need to take the embryos out from the incubator to check them and to look at them under the microscope. So with that incubator, the embryos are there for the whole procedure, and we just, and also they would have like constant and stable conditions in terms of temperature, oxygen, and light exposure. So they won't change the conditions at all. And apart from that, we'll have more information about them. As the camera is taking pictures every 5 minutes, it means that it could be a really good way to have more information about when the embryo divides, when the cells start like compacting. So in the end, that information can also be very helpful for the biologist to select the best embryo to transfer, and also the embryos that should be frozen in the event that there are more than one. In addition to that, as I was explaining before, we were explaining that the most important part from that implantation procedure is the embryo first, and then the other factor that we were talking about before. So the idea is that if we have a good quality embryo, as I was saying before, it doesn't mean that the embryo will have no abnormalities in the chromosomes. So when the embryo has certain problems in the chromosomes, the chances of implantation with that embryo are much lower. So we normally indicate that pre-implantational genetic screening in patients that, for instance, might have problems in the karyotype. So sometimes we find some alterations such as deletions or translocations in the karyotype that should be also be tested in the embryos. Also, if we, like a patient has like repeated miscarriages, and also some kind of and also failure of implantation is also one very good indication. And finally, patients that might have like some kind of this genetic disease that has to be diagnosed in the embryos, right? So it's also possible to diagnose certain diseases, well, genetic diseases in the embryos before transferring them, to avoid having a baby affected by that genetic disease. So in the end, the PGT-A and well, the genetic diagnosis is designed to lower the risk of transferring that, well, let's say, non-healthy embryos that in the end will end in a miscarriage or in a failure of implantation. So one of the best strategies we might have is doing that PGTA. Of course, in many occasions, the only problem we have is the advanced maternal age. So in that group of patients, it's a good option and technique that can also help our patients in achieving the pregnancy. So in this slide, you might see how the rates of getting healthy embryos might change depending on the age. So as we get older, the number of potential healthy embryos we expect will start decreasing. So that's the reason why we normally suggest doing this kind of techniques and using those techniques in patients older than 37, 38 years old, because it's the moment when the risk of having miscarriages and repeated failure of implantation will start increasing according to the potential number of non-healthy embryos we expect related to their age. So, as we were saying before, we were talking about the embryo, which is the most important part, like the basement of the house we are trying to build. So we're saying that we also should be quite exigent in, let's say, studying the endometrium and the uterus, and also the immune system. So talking about the uterus, as I was explaining before, we should also try to get focused in the endometrium. So there are different tests that are designed to know more about the endometrium. So as I was explaining before, one of the reasons not to to have failure of implantation or also repeated miscarriages could be chronic infections that could be quite as I was saying, a chronic endometritis, which in the end means chronic infections in the uterine cavity that in the end can end in those problems. So there is a test called MITA that gives us the chance of checking that potential chronic endometritis in the uterus. So we are able to know if there is any kind of infection first, and we can also check the microbiome to know more about that environment that the uterus has. So sometimes we need to find a good balance between the good bacteria and the non so good bacteria in the uterus to find, if possible or if needed, the best treatment for those patients. In addition to that, it's also possible to check what we call the window of implantation. That can also be a factor. So we know that the window of implantation, which is checked in the test called time, is the moment when the endometrium is most receptive for implantation, which means that we could have higher chance of implantation if we transfer the embryo in that window. So it's true that this test in some cases is not indicated for everyone. It's true that it could be also controversial, but it's also useful in certain group of patients. Of course, we don't offer this test for all patients, but we should be quite we should have quite clear in our mind what patients could find a benefit in using this test. So in the end, when we're talking about a failure of implantation, this test can also help us in personalizing the embryo transfer and doing the transfer in the best moment for the endometrium of the patient. Talking about the uterus, as I was saying, we should get focused first in the endometrium and also in the uterus itself. So it's true that sometimes we might find some problems that can be also seen in a normal ultrasound, such as polyps, fibroids, and some kind of malformations in the uterus. So we normally suggest doing a special test called 3D scan, 3D ultrasound, in which we are able to check any kind of potential abnormalities or abnormality of the uterus. We can also examine the uterine cavity to know if it's the size and the shape of that is good enough for implantation. And we can also exclude some kind of problems such as adenomyosis, which is quite frequent to find. And in the event that we find any potential factor that can in the end affect the implantation rate, those factors should be treated before the next embryo transfer. The same happens with the ismophthele and other problems that should be treated before the next embryo transfer. So in addition to that 3D scan, The hysteroscopy, which is the gold standard, is a really good technique to check the uterine cavity to make sure that everything is fine in that way. It's true that the hysteroscopy won't let us know like about all the adenomyosis, because sometimes we are not able, of course, to see the myometrium, which is the muscle of the uterus, with that hysteroscopy, but at least we have like a good option to take samples if needed, and we can also check the uterine cavity. And in the event that we find some kind of polyp or fibroid, we can in the same procedure we can also have the chance of removing those polyps or those fibroids normally. So we have been talking about the embryo first, then the uterus, and we were saying in the first slides that it's also important to have a complete and let's say a different perspective of the clotting and immune system problems. So sometimes we also prescribe those tests that normally are done with a blood sample to know if there is any kind of genetic thrombophilia, or if there is any kind of marker related to the antiphospholipid syndrome. That should be also treated because they have proven to reduce the implantation rate of those patients, and also are related to a higher risk of having certain problems during the pregnancy. So some patients might need to use heparin or even aspirin or both of them. Same happens with the immune system. So when we are thinking about having a complete approach of the problem, so it's quite frequent also to do let's say quite a wide examination of the immune system to know as much as possible about that and find out if there is any kind of extra or adjuvant treatment that has to be used, such as steroids or sometimes intralipids apart from the heparin. And so in the event, it's also important to have the immune system in the best balance possible, with the idea of maximizing the chance of success. So of course, when let's say the normal procedures fail, we should also talk about, apart from doing the normal IVF, we sometimes have to discuss the option of, if we have a patient that has like a poor egg quality or a low ovarian reserve, and they have tried several times with IVF, sometimes we need to start talking about other techniques such as egg donation, for instance. So when we have to face like the fact of having a severe male factor, it can also be like maybe the main reason to have also a low quality embryo. So some patients have to also, we need to discuss with them the option of doing like the treatment with donor sperm. That can be also a good option for those patients. So the way we select donors according to the Spanish reproduction law, we have some criteria that includes like the age. Of course, we need to exclude, and it happens to male and also female donors, like certain problems in the family and also in themselves. And we do a rigorous selection regarding the tests that are needed, and we always we're always following the instructions that have been designed in the Spanish reproduction law. Okay, so we were saying also in the previous slides that sometimes when there is no more chance of moving forward with the patient's gametes, we should at least discuss the option of doing a treatment with donor eggs. The most common indications are the low ovarian reserve, advanced maternal age, also low egg quality, also some hereditary diseases that can't be detected with the normal genetic techniques. Also, a poor response to ovarian stimulation that is also related to sometimes advanced maternal age, and of course repeated miscarriages or after repeated and multiple failed IVF cycles. So in the end, it's true that sometimes we should discuss different options for that patient. So talking about donors, as I was saying before, the way that donors are selected and are, let's say, allowed to donate we need to follow the instructions that the Spanish reproduction law say. Apart from that, in our case, like almost, I would say that more than 90% of donors are younger than 30 years old. As I said before, many of them are already fertile. Of course, we need to exclude like some kind of familial diseases, and we also perform many tests before donating to try to, of course, do the test, the treatment in the best conditions and, of course, with the lower risks possible. Okay, so, well, apart from the way donors are selected, we, apart from knowing like the most, let's say, as we always look at the physical appearance of the recipient of the patient, and we also use a technology called Phenomatch that will do like a facial biometry to know the difference between. Well, in the end, it's designed to know the difference between your eyes, the nose, and so, with the idea of maximizing the options of selecting the best donor for each patient. It's also possible to do an additional technique, which is the genetic matching, with the idea of reducing the risk of having a baby affected by a genetic disease. But as I said, these techniques are like more designed to select donors that can also help us in finding the best donor for each patient. And as happens to other fields of our life, the artificial intelligence is also helping us to select the embryo. So we are currently using a test called Chloe. That is a program that is designed to help our biologists in the embryo selection. So it gives like a score to the embryos, and we also consider that information. So in the end, it's designed to help us in selecting the best embryos for the transfer. So it happened with the Matrix project that is designed to analyze like the endometrial thickness and endometrial aspects to try to improve the chances of implantation with the embryos we are transferring afterwards. So finally, just to summarize what we have been talking about, as I was saying before, in the end, when we are facing a patient that has a failure of implantation, it's really important to have an experienced and multidisciplinary team to have the chance of going through all the factors, trying to maximize the options of succeeding in the following attempt. It's important to do a really good diagnosis and also to find the proper treatment for that patient. As we were saying before, it's also important to use the latest techniques and technologies in assisted reproduction. And of course, each patient has to follow a personalized treatment depending on their case, depending on the problem we have found out, and we need to find, let's say, like the most accurate treatment for each patient. So we also understand that those processes are very, very emotional. We understand how difficult it could be to deal with them. So it's also important to have a good support, and of course to have an individual treatment plan to go through all this process with the idea of succeeding in the end. Thank you so much.
Brilliant, as always. Thank you so much for walking us through all aspects, of course, explaining what to do, what can be done in different situations as well, of course. And now we will go for your questions. So I do see them. Keep them coming. Go for your questions. There are plenty of those right here. We will start with them one by one. The first one from Martha, I think here. Yeah. So do you consider adenomyosis a significant factor affecting implantation and pregnancy continuation in IVF cycle? And if so, what are the recommended treatment options to improve outcomes? Adenomyosis, is it a significant factor? Yeah, affecting.
Yeah, of course it could be. It also depends on the kind of adenomyosis we are talking about. But in the end, I mean, some kind of cystic adenomyosis, if the adenomyosis interrupts like the junctional shown, it could be a factor to have a failure of implantation. So in the end, the strategy depends on first, like the kind of adenomyosis, and also depends on the treatment that the patient has done. So of course, generally speaking, when we have a patient in that condition, we try to down-regulate her hormones. We try to put them for 2 or 3 months, like on a kind of a menopause, trying to lower the production of hormones to reduce that potential negative effect that the adenomyosis may have.
All right. I hope that answers the question. Thank you so much for that. And let's see. And what do you think of the supplements recommended in the book? It starts with the egg. I'm not sure if you're familiar with that particular one. And besides, melatonin, what are the key supplements in your opinion? What about ubiquinol, for example? Anything else?
In the end, it's true that many different supplements, ubiquinol, also like the coenzyme Q10, the inositol, are supposed to improve the egg quality. Of course, it's very difficult to know if the effect they might have would be so important to be significant for the following IVF rounds. But of course, it might help. Why not?
Okay, keep that in mind, definitely. We've done a couple of webinars on that. This is also a common question, of course, so you can always have a look. There are plenty of supplements, of course, but we need to be careful with them as well, right?
Yeah, absolutely.
Thank you so much. Let's have a look. So my doctor has suggested ERA test after 5 implantation failures, even with donor eggs. How long is the ERA test valid for? Would doing a hysteroscopy affect the validity of an ERA result? I can show it to you as well here.
So, well, I think that doing the ERA test would be a good option. And in addition to that, I would suggest also maybe adding to that ERA test, the other part, which is called Emma and Alice, which is the one which is designed to examine the, as we were saying before, the chronic endometritis and to know about the endometrial microbiome. So in the end, maybe I would do everything with the idea of knowing as much as possible of the endometrial environment, let's say like that. So then the ERA test, we normally recommend doing it as close to the embryo transfer as possible. And normally it's it's supposed to be valid for around 2 years, but it also depends on what happens. I mean, if the patient gets pregnant, if they're having any kind of surgery in the uterus, maybe it can change. So we should also personalize each case to say if it's needed to repeat the ERA test or not. And the third question that was about the hysteroscopy, I would suggest maybe doing the hysteroscopy first to check that cavity and to know if there is something that has to be solved in that way, and then doing the ERA test to have the endometrium in the condition that would be more similar to the one that will be for the real embryo transfer.
Okay, again, brilliant. Thank you so much. And in the meantime, let's see the next question. I will skip this one, but of course, I will get back to it. So how long is hysteroscopy valid for?
I mean, it's not a matter of being valid. If we say that there is nothing, maybe the patient do not need to repeat it in the future. So it will depend on what we find in the hysteroscopy. If there is a polyp, we remove it, but at some point, if we suspect that there is another polyp, we need to repeat the hysteroscopy. So it depends on the results of that.
Again, yeah, this is definitely personalized approach to again. So someone also said, I am allergic to heparin. Is there an alternative?
I think there isn't. So because in the end, the aspirin has a different way to act, and there are some other anticoagulants that are not allowed in the pregnancy. So this is something that has to be discussed maybe with the hematologist, but I think that is not an option. There is not an option for an allergy to heparin. Yeah, I'm afraid.
Okay, thank you. I will show you the next question. So what is the difference between ERA test, the ES time, and ES meta?
Well, there are no difference in the end. It's the name of the test, depending on the laboratory that is like doing it. So ERA and the S time are the same, and the S meta. So the meta is exactly the same as the Emma and Alice test that I was talking about before. So they are the same, but different laboratories.
Yeah, okay. So there are just different names, of course, different laboratories, but basically it's the same kind of test. So just so you know, I hope that is clear. I do believe so. And when do you recommend egg donation if the egg quality showed to be poor? After how many unsuccessful IVFs?
Well, it depends again on the age of the patient first, and on the limit that the patient wants to put. So in the end, it's true that it's not a matter of saying, okay, 2 rounds of IVF, 5 rounds of IVF. It's true that some patients want to keep on trying anyway, and they don't feel like ready for egg donation. But some others understand that the prognosis is what it is, and it's difficult to keep on trying with their own eggs, and they are happy in trying with donor eggs. So in the end, it's not so clear to say, okay, just 2 or just 5 or just whatever. So it's a matter of like personalizing the treatment depending on the case we have.
Definitely. And of course, if you have had a chance to also join our previous webinars, sometimes there are people that even put in the questions. I had 10 or even 15, which is something unimaginable on one hand, but of course, remember, all has to be personalized, right? So it's definitely important to remember this. Thanks a lot for the question. And let's have a look. There is a bit of a history here, so I will need to show it to you from Belinda. 45 with low ovarian reserve male factor, usually produce 3-4 follicles, but conversion rate is good, making 1-2 elastocysts. We have done 11 egg collection, 10 transfers, just as I mentioned sometimes, right? Using IMSI over last 5 years, but do not want to do PGT testing, so I understand most likely transferring abnormals. I did fall pregnant in 2023 with 2 blastocysts transferred, both implanted but miscarried. At 8 weeks, we done ERA, Emma, Alice test, just done hysteroscopy in December, had endometritis, so treated with antibiotics. I know we need to consider donor eggs, but want to try one last time, right, with own eggs. What's your thoughts on estrogen priming, letrozole, anything else?
Yeah, all those strategies might help in like giving at least a chance of increasing a little bit the response. But as she already understand for what happened before in her case, like being 45 years old, in many occasions, I could say that maybe almost all the embryos that she transferred could have been abnormal in the chromosomes, and that's the reason why they didn't implant in the past, or they implanted and she finally ended in having a miscarriage. So it's true that it's possible to use those strategies. Letrozole is fine, and also using the estrogen priming. So, but the main factor is the embryo. So even though it's true that her ovary seems to respond at least like fine related to her age, on the other hand, it's true that it's quite likely that the main problem is being just the embryo and the abnormalities that those embryos might have. Yeah.
Okay, thank you. Again, Belinda, if there's anything else, you know what to do. Just type this in. How can hormonal imbalance be addressed? This is the question. How can hormonal imbalance be addressed?
Well, it depends on what kind of hormonal imbalance we are talking about. If we are talking about the thyroid, for instance, we need to find like a treatment to have it in the, like, let's say, completely balanced, because it could be important. If we are talking about maybe a polycystic ovarian syndrome that also have the typical imbalance on the hormones, in that way there is no like a way to balance those hormones. Maybe it's like we need to get focused more in the way we stimulate the ovaries for the IVF. So in the end, there is no like a way of treating certain like changes that normally women have. So maybe it's more like a way of finding like the most like the best treatment for each patient if needed, because maybe if someone has any kind of problems in the hormones, we can't do much, but at least we can try maybe to find like a good way to stimulate the ovaries if needed, for instance.
Okay, thank you. And I will go right to the question from Belinda. Okay, so she just added this. What's your thoughts on DK, alpha? We just got our results that me and my husband are a partial March. Do you think lit treatment helps?
Well, regarding the DQ genes, that's something that normally like is like related to the immune system, and so depending on the like the genes that are like shown, and so the immunologist decides if it could have like any kind of impact. Some of them can be related to like to celiac disease, and so sometimes we just need to like to recommend the patient a gluten-free diet. But of course, it depends on what it is. So that's something that is more related to the immunologist than the general gynecologist.
All right, of course, thank you. Now again, some history here. So 41-year-old, I initially had a good IVF track record with no significant fertility issues, successful ICSI pregnancy at 39. However, for my second child, I faced more difficulties, 2 miscarriages, cysts that needed to be removed, AMH tested this summer at 0.4. My latest stimulation in January only gave 2 follicles, leading to an escape IUI. Given my case, are there any approaches or specific treatment strategies you would consider most promising to improve my chances?
Yes, considering that she's now 41 years old and has a low AMH, I would suggest maybe like thinking in doing that PGTA to the embryos and maybe doing a dual stimulation. So considering that the last round, the response was like suboptimal, so it can be done like a new stimulation with the idea of retrieving that 1-2 eggs, fertilizing them, like creating the embryos, doing that biopsy on the embryos, and then after that, like some days after having done the first round of the first egg retrieval, it's possible to start a new round. So in the end, we are seeing how the ovaries respond in that different moment of the stimulation, and then it's also possible to have a higher number of potential embryos to be tested in a shorter period of time.
Right. Thank you again for your question and your help with that. I think that more or less 10 minutes to go, and there are some few questions here. So let me have a look. So Becky would like to know, with egg donation, do you guarantee a number of blastocyst embryos per collection or minimum number of eggs collected? Is donor egg more common to be a fresh transfer at Tambre? These are those 2 questions.
So regarding the first question, we guarantee a minimum number of blastocysts at the end of the procedure. So there are different packages, and depending on what the patients choose, I mean, they can choose between 1 to like 3 to 5 blastocysts. So we guarantee that minimum number. And regarding the second question, it depends on the patient. Some patients prefer to do the first embryo transfer with a fresh embryo, and that's fine for us. But it's also true that I would think that maybe around 80% of patients prefer to freeze the embryos in advance so that they can do the treatment in a more relaxed way, knowing from the beginning how many embryos they have and doing the preparation when it works better for them.
Okay, there are options. So of course, I hope that helped again. Thank you so much. If you opt to do PGTA and biopsy the embryo before implantation, does that affect the timing of when the egg can be implanted? Basically, does doing the genetic testing decrease the implantation success?
Actually, what we normally do is we do the biopsy and we freeze the embryos, right? As we need to wait for some days until the results of that test are ready. It's also possible to have the results in just 24 hours, but we are not, let's say, fans of doing that, because in the end we are transferring the embryos later than normal, and it can also affect the implantation, the window of implantation. So we prefer to freeze the embryos. Then, after knowing the results of that PGTA, start planning the embryo transfer. So the PGTA, even though it's an invasive test currently, maybe in the future it won't be like that, but nowadays the one which is like the gold standard is an invasive test, and it's designed to increase the implantation rate because we are selecting the embryos that will be transferred with higher chances of implantation.
All right, brilliant. Thank you again. Short question: PGTA with egg donation, yes or no?
Well, it depends. I mean, if it's the first round of the patient, if the sperm is fine, if we don't have any other, let's say, abnormalities, if the DNA fermentation is fine, generally speaking, it's something which is optional, and it's something that we do it if the patient wants to do it. But on the other hand, it's not mandatory, right? So in that maybe first round, in the initial case, I would say no. But if we are talking about a patient with repeated failures of implantation, previous cycles, a male factor or so, I would say yes. So it depends on the case as usual.
Of course, there's no easy yes or no question, huh? But it's how it is, of course. So we need to just follow that. Would you recommend PGTA after 2 last 5-day embryo failed transfers? I think.
Well,
that's what it means, I think.
It depends on the age of the patient, and also, but I would say that, I mean, generally speaking, well, it could be something that can be proposed to the patient. Of course, if we are talking about patients that are extremely young, if they are very young, of course, maybe it's just a matter of keep on trying, which is also an strategy that some clinics prefer to do, just keep on trying with the same embryos, because at some point they are supposed to implant. But if we are talking about maybe older patients, in that case, maybe I could suggest doing the PGTA then.
Okay, thank you. Next question, again, an interesting question. So we usually omit this part when it comes to male partner. This is the truth. But how does it affect the success of IVF? My husband is 54 and has good enough sperm analysis. With no DNA fragmentation, I'm 49. We were suggested to go for embryo adoption by some doctors. Why by others to go by egg donation only? What do you think?
Well, we know that even though the sperm sample is like, let's say, has like good quality, and also, let's say, that is supposed not to have major problems, we know that the advanced male age is also related to certain problems in the babies. So it's quite clear that babies that are born from parents that are older than 50 years old might have an increased risk of having problems related to the heart, so cardiological problems, and also psychological and psychiatrist problems. So in the end, some patients are, aware of that, and they prefer to avoid this risk. So sometimes it's not just the fact of having a good sperm quality that is also important to know. It's more like the fact of having certain risks. And of course, we can't, even though the sperm quality is fine, or also the DNA fragmentation is fine, in the end, we don't know like everything about the sperm, and using a sperm donor will be also an option. But some patients say, okay, I understand that the risk is there, and I prefer just to move forward with no changes, which is also an option.
Okay, so this is what you definitely need to think about. Yeah, thank you so much. It's a good point as well, I think you mentioned here. Thank you. Let's have a look. Some studies claim that the implantation window may change and may not be the same in each cycle. Does this mean that the ERA test would only be valid for that one cycle when the test was carried out?
It's true that, as I was saying before, the ERA test could be controversial. One of the reasons is that one, because if the endometrial the endometrial tissue like renews every cycle, maybe there could be also like an impact in the way of the window of implantation. But the research that has been done shows that at least that window of implantation is supposed to be quite stable if nothing changes in the endometrial conditions. If there is an endometrial surgery, of course it can change. In addition, if let's say if we use a certain treatment to prepare the uterus for that ERA test, and we change the treatment, of course it can have an impact in that window of implantation. So in the end, talking in general, it's true that the idea was that maybe it can change every month, but what the research has shown is not like that. So that window of implantation is supposed to be quite stable in the following months after having done the test.
Okay, thank you. Let's have a look. More questions are right here. I had many immunological analyses done in 2021 and all were good. We had 3 failed transfers in the meantime with egg donation, 2 failed implantation, 1 miscarriage at week 8. Should I recheck my immune status? I am 49 and approaching menopause with very rare menstrual cycles.
Well, maybe apart from, maybe checking again that immune system, because in the end, the molecular status can change between, time to time. So it would be also a good option. And considering that she also had a miscarriage, I will also check the uterus and the endometrium to check if there is any kind of abnormality in the uterus, and also to check that kind of a potential, let's say, chronic infection. So maybe apart from the immune system approach, it could be an option talking about the uterus and so.
Okay, all right, thank you. Short question, how can we calm the contractile uterus after an embryo transfer?
Yeah, so this is quite a recurrent question. So it's supposed that when we do embryo transfer, that process should be quite soft and quite, let's say, careful to avoid any kind of uterine contractions. So the progesterone is a good way to relax the uterus. In certain occasions, it has been using in certain clinics like some medication to try to lower that potential contractions, but they haven't shown in the publication that they could be useful, because some of them are supposed not to have like so many receptors in the uterus. So at the same time, it's true that if the technique we use to do the transfer is the one that we should use, apart if the embryo transfer is easy, we can reduce the chances of having that contractions in the uterus.
Okay, brilliant. Thank you so much. There are like 4 questions left and we will be finishing, and I think we can still answer those. Let's have a look. So a few details again. I had a fresh embryo transfer with donor eggs 3 months ago, which unfortunately didn't implant. Since the embryo transfer, I have been experiencing light spotting 3-5 days prior to my menstrual period. Could the medication taken for transfer have caused this issue of spotting? I had a hysteroscopy last year. It was normal. No issues found.
Well, in the end, it's true that sometimes we also have the same complaint from patients saying that their cycles have changed after the treatment, that they feel different. Maybe they also have that intermenstrual spotting. So in the end, it's true that the hormonal treatment can play a role on that. So it's not because of the failure of implantation. So it would be just because the body needs some time to adapt to the new situation. But if the spotting keeps on appearing, it would be a good option to, of course, repeat ultrasound and to discard any kind of other problem that can have appeared in the last time. Yeah.
Okay, again, I do believe it was helpful. Let's have a look. Stephanie would like to know, do you have experience with successful embryo transfer into an endometrium that was treated by anti-hormone therapy? You can see the details here. I'm not sure about them. So against endometrial cancer, after my cancer treatment, I am planning for an ICSI. Are there any success stories that a formerly cancerous endometrium can successfully grow the embryo to full term?
Yeah. So yeah, of course, we had patients with similar conditions. So the main problem is that, well, in her case, after being recovering after the cancer, and so it's true that we need to see how the endometrium grows. So it's true that it could be an increased risk of having a thin endometrium. But I mean, if we are able to make the endometrium respond to the medication in a good way, the chance of having an ongoing pregnancy are pretty high. Yeah.
All right. Again, thank you so much. Belinda has another question. So do you try metformin 500 milligrams once a day for your older patients who do not have PCOS and found it to help mature eggs?
Not for that goal, to be honest. So we always just use the metformin, of course, for patients that have any kind of resistance to insulin, but not to get a higher rate of mature eggs, not for that.
Okay, crystal clear. Again, brilliant. Thank you. So does an immune protocol impact the endometrial receptivity? Could an ERA test performed with no immune medication yield a different result than the protocol used for embryo transfer?
Well, that's something that happens in many times, because when we decide to maybe prescribe some tests, sometimes we don't know about the immune system problems, so we start maybe doing the ERA test and then we know about them. So what they suggest in the laboratory is trying to do like the treatment in the most like similar way than the way you are doing the embryo transfer. So the idea is that we normally, for instance, if the patient normally uses heparin, we try also to use the heparin for the ERA test, because it has shown that it can like change the receptivity of the endometrium. So it would be the one that we normally use. The other ones, such as the prednisone and so, are supposed not to affect the window of implantation so much, but in the end, we try to do like the preparation for the ERA test as similar as the one for the real embryo transfer, but of course accepting some kind of like maybe immune system treatments like the intralevis or so. We never use them for the preparation for the ERA test, but we try to do the treatment in both cases like the most similar one to the other.
Okay, again, thank you so much. And I do believe it will be final question for today. So let me show it to you. Then I would like to know some 36 2 rounds of ICSI with 2 fresh transfers, then 3 frozen embryo transfers. One of the transfers we were transferring 2 embryos, all failed. Would you recommend transferring 2 at a time going forward, depending on the amount of embryos? All have been high graded, but no success.
Well, it depends on the, let's say, basal condition of the patient, apart from the age. So the patient is 36 years old. So, I mean, it depends on the risks the patient that is facing, right? So, I mean, if there is no like additional problems, if there is no obesity, no high blood pressure, I mean, the patient is young and it's having, let's say, like it's doing fine. So in that way, it's possible to take the risk, even though a twin pregnancy might happen and will increase the risk of having complications. So sometimes if the embryos are good quality embryos, we always suggest going one by one, because in the end we transfer 2, it's so that you can have a slightly higher chances of implantation, but at the same time you are increasing the chance of having a twin pregnancy. So in the end, we also need to find a good balance, and also we need to communicate to our patients to find like the best strategy for them.
Brilliant. Thank you so much. As I mentioned, that seems like that was our final question. But of course, if you have any other questions, you can either get in touch with me. I'll be happy to forward any questions to Clínica Tambre, Dr. Esther Marbán and her team, or you can simply get in touch with them directly, and I'm sure they will be happy to provide you with some more details as always. And thank you everyone for joining. I do see your comments here. Dr. Marbán, as you know, it's always a pleasure to have you. It's always great, and you've been very, very helpful. And well, you can see for yourself that there are only good comments. So thank you so much indeed for everyone for your time as well. Before we finish, any final words you would like to share?
Yeah, I'm just, well, as I always say, it's a pleasure for me to have like the chance of giving like maybe some light to that topic, and also I'm always happy to answer the patients' questions. We understand that it's a very like challenging problem, so we are here to help them as much as possible, for sure.
Definitely, and I can only encourage you to join our next webinar. Of course, we will be back next week, but I'm sure Dr. Marbán will be back with us, so you can also have a look at her previous webinars. They are all interesting, and we mentioned this before our event, that she has like a record. We did a webinar that lasted 1 hour and almost 2 hours, if I remember correctly, so you can have a look at this. So she's always great to provide some more details, so don't hesitate. That's from me for sure. And I just want to also encourage you, after we finish, you will be redirected to our website where you can share your feedback. So please do so. Let us know what you think about this particular webinar, but of course, about all of our previous ones. And also, if you have any topics that you would like us to discuss, you can put this information there and we'll be happy to take a look. And simply, we are definitely here to support and talk about as many topics as possible, just to give you some answers and give you some hope as well, I hope. And thank you so much for your time, Dr. Marbán. Lovely to see you. I'm sure we will see each other soon. So
Sure.
thank you. Have a lovely evening, everyone, and see you soon. Take care. Bye.
Thank you, Caroline. Bye bye.